So we're going to be hearing a lot this afternoon about all of our new and emerging therapies for psoriasis, a lot of biologics. So I'm going to take some time to talk and give an update on our traditional treatments, what's new with what's old, if you will. And I would argue that there's still a very important place for these treatments in our treatment arsenal, especially when we're considering cost and patients for whom we can't get a biologic approved, or you get it approved, but their copay is just unmanageably high. So the first part of my talk today, I'm going to be focusing on strategies for optimizing management with the traditional therapies, and we'll focus mostly on the systemics. Dr. Temecki did a wonderful job yesterday of setting the foundation with all of these treatments in the setting of atopic dermatitis, and I'm going to give some hopefully practical strategies for your practice, kind of building on that, specifically in the setting of our psoriatic patients. And then we'll talk about some developments in phototherapy. That'll be sort of an evidence-based potpourri of topics. And then we'll delve into the question of methotrexate safety, specifically in regard to liver fibrosis, and try to answer this clinical question of whether liver biopsies are really necessary in our methotrexate-treated patients. So we'll talk first about some strategies for optimizing our traditional therapies, and we'll start first with methotrexate. So I think many of us know that if you have a patient that you have on oral methotrexate and you're getting a response, but it's not as good as you want it to be, you can switch them to subcutaneous methotrexate. There's a little bit better bioavailability. You might be able to push their response a little bit. But I think as dermatologists, we tend to stay a little bit towards the mid-range of the dose of methotrexate, and we can remember that we can push the dose a little bit. And there's this excellent trial that was published in The Lancet very recently that looked at this issue. They started patients a little bit higher than we usually do at 17.5 milligrams and increased them up to 22.5 milligrams weekly. This is sub-Q methotrexate after 8 weeks if they weren't getting good improvement. And they actually had pretty respectable PASI scores. I mean, these weren't PASI 90s. It's not as impressive as we're seeing with the biologics, but 41% of patients achieved PASI 75 at 16 weeks, and it was very well tolerated with a low rate of serious adverse events. The one thing I will point out is that in this study, because they were at a little bit higher dose, they did supplement with higher dose folic acid. So if you are going to push the dose of methotrexate, it's a good option in some patients, but you might want to consider giving 5 milligrams instead of 1 milligram of folic acid. So when can you tell if your patient's going to respond to methotrexate, or if you're going to need to escalate this patient to a biologic? And I think in general, we tend to bring our patients back at 3 months, and we make the decision at that point, but do we really need to wait that long? So there was a trial published in the JAD recently that did some predictive modeling, and they did that based on patient characteristics at baseline and also early response in those patients. And what they found was that patients that achieve PASI 25 at week 4 are very likely to go on to reach PASI 75 at week 16 on methotrexate. And in fact, 66% of those patients did go on to achieve PASI 75. So what do we take away from this? 4 weeks is probably adequate to assess response in our methotrexate patients, and we may not need to handhold them through an additional 2 months to get to that 3-month point. If they're not getting any response at 4 weeks, you can probably consider switching therapy at that time and save them a little bit of discomfort. And anyone who is getting good response at 4 weeks is probably going to do very well and may likely reach PASI 75. So we'll switch gears a little bit and talk about cyclosporin. So we tend to think about cyclosporin in our treatment arsenal as something that gives us very rapid control of disease. Dr. Temecki talked about this. It works within 2 weeks. It's very quick, but it's not a long-term treatment for patients. So it's something we're always thinking, what am I going to transition them to? But there are 2 case series that were published recently that provide some evidence, even though they're small case series, that we can probably treat patients for a little bit longer with cyclosporin. And that's, of course, in the right patient. So it may be someone where this is just their preference, someone who has insurance limitations, they failed methotrexate, cyclosporin works well for them, or somebody who, for whatever reason, has contraindications to other therapies. So in the larger case series, patients were treated up to 34 months with cyclosporin. They had very good responses, but there was a pretty significant rate of adverse events. It was about a 50-50 split in that 40% of patients between creatinine elevations and hypertension. But I will point out that this did not limit treatment in those patients. 3/4 of them were able to continue therapy. It was reversible. They just had to modify the dose a little bit. And in those patients who had trouble with adverse events, there was a very strong correlation with metabolic syndrome, and that's a theme we'll see throughout the talk, that those are the patients who struggle with these traditional therapies. And in the other series, it was a little bit smaller, only 5 patients, but they were treated out to 62 months. They did very well, so 100% PASI 75 in these patients and no adverse events. So it's something that you can think about, again, in the right patient. You obviously want to taper them to the lowest effective dose as soon as possible, make sure they're not on any concurrent nephrotoxic medications. Consider rotational therapy with something else, maybe one of the other traditional therapies, and then watch people with comorbidities very closely. So not a whole lot new with acitretin, but this is something, there's a little bit of buzz about curcumin right now. Your patients may be asking you about it. People like natural alternatives and supplements that they can take. So this is a randomized control trial that's pretty hot off the presses, just published in March, that's looking at patients with moderate to severe psoriasis who are on acitretin. And they randomized them. They gave half of the patients this nano curcumin supplement. For anyone who's not familiar, it's an over-the-counter supplement that's derived from turmeric that is thought to have some anti-inflammatory benefits and some benefit in the literature in osteoarthritis. They gave a nano formulation of curcumin, 3 grams a day. So because it is a little smaller particle, there's a little bit better absorption than what you can get over the counter, but it is readily available over the counter. They treated them for 12 weeks. And what they found was that these patients actually had better efficacy with their acitretin treatment. So they had a significantly greater reduction in their PASI score in the curcumin-treated patients, and then it did help them with potential adverse events. So their serum cholesterol was unchanged from baseline. So it's something that might help efficacy. It's cheap. It's available over the counter, just something to think about that's attractive to patients. So this dovetails nicely with Dr. Cooper's talk. So how do our traditional therapies stack up in terms of helping with these comorbidities potentially? So we'll talk about cardiovascular disease first. There are a whole bunch of different traditional therapies, and some of them really have no benefit at all in helping with cardiovascular disease. So phototherapy, no benefit. Retinoids, no benefit but no increased risk. Maybe some theoretical benefit to mycophenolate mofetil and cyclosporin, but methotrexate is really where the money is here. So there's a 21% lower risk for total cardiovascular disease in patients treated with methotrexate who have psoriasis, and then 18% lower risk for MI. So there's not enough evidence to really tailor our therapy at this point completely based on these cardiovascular benefits, but if you do have a vasculopath patient and you're choosing therapy, probably either methotrexate or a TNF biologic has the best evidence of helping. So what about metabolic syndrome? So I'll just go through this very briefly. It's a study looking at an arm of patients on biologics and an arm of patients on methotrexate. They did actually see improvement in these metabolic syndrome parameters in the patients on biologics, not so for methotrexate, so not as helpful in the setting of metabolic syndrome. So if you do have a patient with metabolic syndrome, biologics or your small molecules like apremilast are probably going to offer the most evidence of benefit. So just a really brief word to remind us about safety with our topical corticosteroids. So this was a study looking at psoriasis patients with 16 to 20% body surface area, and this really just confirmed what we know. The higher potency topical corticosteroid that a patient's applying, or the larger the body surface area, the more evidence of adrenal suppression they're going to have, and in these patients they did have lower post-cosentropin cortisol level. But interestingly, when they looked at patients who had lower body surface area and were using lower potency topical corticosteroid, they did have a lower cortisol stim level than healthy adults and evidence of silent adrenal suppression. So it does occur in the real world setting, and it's just something to keep in mind. Even if you're just prescribing topicals, educate your patients because in the event of trauma, this does potentially put them at risk. So we'll talk about some developments in phototherapy, and what I think is most interesting is now that we're learning more about the inflammatory cascade that sets off psoriasis, we're learning a little bit more about how phototherapy works, and that has some interesting implications for future therapy. The one thing that is actually new, there's not a lot, the one thing that's new with phototherapy is that there are some filters for the excimer laser that block wavelengths below 297 nanometers that in studies at least show increased safety and efficacy, so that's something that might be coming down the pipeline. So as far as pathophysiology and what phototherapy is actually doing, we're learning now that it restores T regulatory cell number and function, and that's part of how it's able to induce good responses in patients. And it does decrease all of the pro-inflammatory cytokines that we know to be involved in psoriasis, but interestingly, it's not those common ones that we think of, IL-17A, et cetera, that are indicative of a better response. It's actually high pretreatment levels of IL-6 that are predictive of better response to phototherapy, and there was kind of that that big complicated diagram that had some really good information in Dr. Cooper's talk that sort of alluded to this IL-6 issue, but they think that it's actually turning off that, like suppressing that IL-6 stimulation of IL-17 cells that gives the good response in phototherapy. So we have a lot of bright, shiny new medications to play with in psoriasis that give some really, really excellent clinical responses, but none of them are durable. Actually, the best data in long-term remission for psoriasis comes from old school Gekkerman regimen treatment with tar and UV light. And why does it give that sustained remission of 4 to 6 months? So there's a little bit of new evidence looking specifically at the bioactive compound in tar, carbazole, which inhibits RAC1 STAT3 signaling. And it's thought that a UV signal plus that signaling pathway is able to induce long-term remission. I think this is very exciting, actually, that we're learning this because now there are animal trials with this small molecule tyrosine kinase inhibitor that actually targets that pathway, and the thought is that combining it with light may actually have some durability for patients and lead to a more sustained remission for those patients. So we'll have to stay tuned. I do want to just briefly talk about a specific patient population for whom these traditional therapies are very important and the mainstay of therapy, and Dr. Calabrese really kind of set off this topic very nicely with his patient case discussion on Wednesday night. Like he mentioned, we don't have a lot of data in this patient population, but what we do have, there are some case reports that we can base this on, and there's a consensus statement that was published in the JAD in 2010 with some guidelines. And far and away, the traditional therapies are first line for these patients. So topicals, phototherapy, and obviously retroviral therapy are first line. Retinoids are something that you can add second line that's very safe in this patient population. But there are some patients with severe disease for whom immunomodulatory systemics can be considered and will probably be required to improve their quality of life. If you're going to consider a systemic, the patient needs to be on antiretroviral therapy, and they need to be monitored very closely to make sure that they're not developing signs or symptoms of infection. Of the traditional systemics, cyclosporin is the one that can be cautiously considered. Methotrexate is not a good choice in this patient population because of the myelosuppression risk. But there is some evidence to show that biologics are probably better in HIV patients because they actually have a positive effect, as we saw in Dr. Calabrese's case, on CD4 count, viral load, and HIV expression and replication. So how do they stack up in terms of cost, these traditional therapies? So this is a little bit of a busy slide, so I'll make it very, very easy for everybody. This is from a study that looked at total US healthcare system costs, and then compared it. On the left, we're seeing comparison with efficacy, so PASI 75 in the chart on the left, and then the quality of life index on the right. So low numbers are good here. So where the money is, or where the money isn't, is right on the left-hand side of all of these graphs. Methotrexate and light give you really high efficacy and good improvement in quality of life for the cost. So these treatments aren't going away anytime soon. They're going to be part of our treatment arsenal as we think about cost-conscious care. So with the rest of my talk, I want to talk about methotrexate safety and specifically focus on the issue of hepatic fibrosis. And I want to try to answer this question: do we really need to do liver biopsies on these patients anymore? And what options do we have that are non-invasive as a replacement for liver biopsy? So reviewing the literature, things that become very readily apparent are that end-stage liver disease in patients treated with methotrexate is exceedingly rare. Fibrosis does happen, but the patients it's going to happen in are patients with other risk factors. So they drink alcohol, they are obese, they have diabetes, they have NASH. It's not just any patient that you treat with methotrexate. So there's a good study here with a good number of patients. It's 20 years of data, all the patients that were listed for or received a liver transplant, and of those, less than 1% actually had methotrexate-related liver disease. So very, very low numbers here, and all of those patients had metabolic syndrome, and there's thought that there is shared pathogenesis with NASH, so that makes sense in those patients. And there's another study here that's from the hepatology literature with a good number of liver biopsies in 71 psoriasis patients. And what they saw was that 40% of patients with risk factors actually developed severe fibrosis at a pretty low overall cumulative dose, so 1.6 grams cumulative dose. But only 9% of patients without risk factors, and none of them developed severe fibrosis. So, all of our guidelines talk about cumulative dose, and that's when we refer and think about maybe getting a liver biopsy, but what we need to really be thinking about are risk factors in these patients. Those are the ones that are going to have problems. So other things to keep in mind with methotrexate fibrosis. It's not an inflammatory process. So concurrent hepatitis may or may not exist in these patients. LFTs measure inflammatory damage. So when we're getting our every 3 months CBC CMP, we're potentially missing silent liver fibrosis. And none of our existing monitoring options are perfect. So what do we have? What's available? So liver biopsy remains the gold standard, but as we know, it's associated with significant morbidity and mortality risk. So do we really need to be doing that for patients? And if we do, at what dose? Do we only do it if LFTs are elevated or abnormal, if the albumin is low? And when we're answering all of these questions, we also need to keep in mind that our psoriasis patients are inherently different from RA patients. They just have more of these risk factors. They're already more at risk when we're treating them with methotrexate. So the first non-invasive modality I want to talk about is Pro-collagen 3 terminal peptide. This is a blood test. It is not currently available in the US, but we'll talk a little bit about that. It was introduced in the late 1980s in Europe, and it's a specific measure of fibrosis. It's recommended to follow this every 3 months, so 4 times a year. And you can actually do this in your practice or in your hospital system. It's very cost effective. It's available as a send out to Central Manchester University Hospital in the UK. You can basically batch them, so have people come in 4 times a year. You don't necessarily get a baseline then because it's not practical, but you send them out 4 times a year, and if you do it that way, the cost is comparable to an in-house CMP. So it's really not expensive to do this. And I can provide more information if anyone's interested on how to send that test out. So we'll talk a little bit about interpretation. These are the Manchester guidelines for how to interpret this test. And I'll just mention briefly that there are a couple of caveats if you are going to use this assay. So because it's a measure of collagen turnover, it's going to be elevated in anyone who's having collagen turnover. So that means anyone who's had recent trauma, anyone who's had recent surgery, and kids. It's elevated the same way ALK-Phos is. So there are guidelines for interpretation in kids, but it's a little bit fuzzy and a little bit difficult. It's also going to be elevated in a certain percent of patients with inflammatory arthritis, but not all of them. So it's only found to be elevated at baseline in 38% of psoriatic arthritis patients. So while it may not be helpful in those patients at which it's elevated at baseline, that's still 60% of psoriatic arthritis patients that could potentially be spared an unnecessary liver biopsy. So some takeaways from the data on this assay. So this is a study that looked at 183 patients with 6-year follow-up. 41 of those patients had serial elevated Pro-collagen 3 terminal peptide levels. For unclear reasons, only half of them actually underwent further evaluation. And of those patients, 14 had evidence of hepatic steatosis. They had higher BMI, longer disease duration. The greater majority of them had a history of NASH. And interestingly, they had a lower mean dose of methotrexate that they were on. So there was no correlation here between cumulative dose and elevated measure of fibrosis. So again, if we're using cumulative dose for when we're referring, we need to be looking at the risk factors. So what about outcomes and cost savings with this assay? So this is data published in the British Journal of Dermatology that looked at a 24-month audit of 4 major healthcare centers in Europe. And what they found was that there was a 7-fold reduction in unnecessary liver biopsy using this assay. And there was no evidence that they were missing liver toxicity in these patients. There was significant cost savings, and when they surveyed patients, they much preferred having a 4-time-a-year blood test added on to their regular blood work than having to discuss liver biopsies. So what else is out there? We've talked about one modality. So there are a couple of imaging techniques that are available now, hepatic elastography, and there are 2 ways that this is done. One of them is ultrasound-based, one of them is MRI-based. There's more data in transient elastography, which is the ultrasound-based technology, so I'll talk a little bit about that. But the MR elastography, which is a newer technology, I would argue is much better and probably much more likely to actually replace liver biopsy in our patients. They both use pulse echo, which measures the stiffness of the liver, and then it's correlated with imaging, either ultrasound or MR. Transient elastography, otherwise known as FibroScan, which is the ultrasound technology, is good at detecting high-grade fibrosis. It's really not good at detecting the difference between low-grade and no fibrosis, and it's limited by obesity. So patients with obesity tend to have invalid scans with this test, so you're not able to actually get a result. With MR elastography, it uses MR imaging, and it has diagnostic accuracy comparable to histopathology, and it's not limited by obesity, and it's not limited by acoustic windows that a technician is selecting. So that technology, I think we need a lot more data on, and it's very exciting. So what do we know about transient elastography or FibroScan? There are 13 cross-sectional and case control studies looking at it in psoriasis patients treated with methotrexate. Very reassuring that there were low overall rates of fibrosis, and only one, again, found association between cumulative dose and fibrosis. The two best studies here, these are the ones that actually correlated with histology. One was a little bit larger than the other. The data is variable here, so not great results. The first study looked at patients who had serial elevated P3P levels. Less than half of them actually were able to get valid scans because of obesity. Only 7 out of 10 had concordance between their scan and their histology. And there was one patient who had fibrosis on biopsy that had a negative scan with FibroScan. So potentially people that could be missed there. The second study, the numbers were a little bit better. So they looked at 24 patients. They did use the XL ultrasound probe. So they were able to get valid scans in 83% of the patients in that study. Sensitivity, not great, 50%. Specificity was 80% in that study. So something that's potentially helpful as an adjunct, but alone, this is probably not going to be the answer for us. So I'll talk very, very briefly about FibroTest. This is another blood test that's available. It is not actually measuring fibrosis in patients. It's actually predictive modeling of risk for hepatic fibrosis. So it uses a bunch of different lab parameters in patients to tell you, are they likely to develop fibrosis? But we already know this in most of our psoriasis patients. We already know these risk factors. So I don't think this is adding a lot to what we have. But again, in a panel with different non-invasive technologies, it might be helpful. So this is a good study. This is from JAMA Derm in 2014, and it looks at combining these different non-invasive technologies. So they had 77 patients that underwent transient elastography. Only 65% of them were able to get a valid assessment. 18% had an abnormal result. And again, what they found is that obesity increased the possibility of not being able to get a valid result, and BMI and age were also correlated with having an abnormal result. So it's exactly those patients you're worried about where you may not get a lot of information with FibroScan. 71 patients received FibroTest, and 16% had an abnormal result in this study. There was no correlation between Pro-collagen 3 terminal peptide levels and TE results or FibroTest results. And 2 patients in their study had hepatic fibrosis. One of them had significant fibrosis and had an invalid TE, so would have been missed if that was the only modality used. But their conclusion here was that the need for liver biopsy could be greatly reduced if we require patients to have 2 abnormalities in, say, 3 of these tests before we consider doing a liver biopsy. So there's a meta-analysis looking at this. These are the sensitivity and specificity numbers for these different modalities. Because MR elastography is a little bit newer, it's not included in this meta-analysis. But the most extensively validated of these technologies is Pro-collagen 3 terminal peptide, and it has the best sensitivity of these tests, so 74% and 77% specificity. And I will also point out that the worst sensitivity is measuring LFTs. So they concluded that the overall quality of data here is poor. So we need more information, but I think this is going to be the future for us. So what can we take away from this? There's no perfect test yet available. MR elastography is really the most promising of these technologies. Non-invasive technologies in combination are better than any test alone. There's significant cost savings associated with them, and we can definitely spare patients mortality and morbidity of unnecessary liver biopsies if we implement these strategies. But we need prospective data. So I'll end just talking about methotrexate safety here. So this is data from a survey of British dermatologists. They do, for the most part, the same monitoring that we do, but 71% of them now measure Pro-collagen 3 terminal peptide. And there's actually newer data I haven't included here coming out of Denmark and the UK to show that since they started measuring that routinely, there have been no reported cases of end-stage liver disease in Europe in patients treated with methotrexate. So potentially a very important adjunct that we can start doing. There were 12 reported patients with irreversible liver damage and 49 deaths reported. And I will point out here, we spent a long time talking about liver biopsies and liver fibrosis. There were only 2 deaths from liver failure. There were 18 from myelosuppression, so we cannot forget about that risk, and 6 from pulmonary fibrosis. And those can actually kill people. So pulmonary fibrosis, of the modalities that we talked about, the only one that could potentially pick that up would be Pro-collagen 3 terminal peptide, which might prompt you to get high-resolution CT or something like that. So could potentially pick up that pulmonary fibrosis as well in those patients. And this is just a retrospective review looking at 218 patients treated with methotrexate. They were on average treated for 17.2 months, and very low percentage of patients that actually had to discontinue treatment because of hepatic or renal issues. So very well tolerated overall, very safe. There was one patient with severe interstitial pneumonitis, so remember that the lungs can be affected. So in summary, what did we talk about today? We went over some strategies to optimize our systemic therapies, specifically pushing methotrexate dose, switching to subcutaneous administration. We talked about the fact that we can potentially treat longer than 1 to 2 years with cyclosporin, curcumin as an interesting adjunct that you can add to patients being treated with acitretin that may boost your efficacy a little bit. We briefly talked about some updates in phototherapy, new filters for the excimer laser, and then interesting potential target for new therapies, RAC1 STAT3 signaling. And then I hope that I was able to convince you that we do have some better options available than liver biopsy for our patients treated with methotrexate. And with that, I'll end.